A patient arrives to the emergency department with sudden neurological deficits such as facial droop, weakness, speech difficulty, or altered consciousness. From this moment, stroke care becomes time critical because time is brain. The patient is immediately shifted to the designated stroke area and the stroke alert is activated. Initial assessment begins with airway, breathing, and circulation. Assess airway patency and level of consciousness. Airway support and ventilatory assistance are provided if there is decreased consciousness or bulbar dysfunction compromising the airway. Supplemental oxygen is given only as needed, with the goal of maintaining oxygen saturation above 94%. Breathing, pulse, and blood pressure are continuously monitored, and intravenous access is secured. A mandatory early step is immediate random blood sugar testing because hypoglycemia and severe hyperglycemia may mimic or worsen stroke deficits. Correct abnormalities promptly. Once stabilized, a rapid neurological screening is done using FAST, and it is essential to document the exact time of onset or last known well time, as treatment eligibility depends on this. A focused neurological assessment such as the NIH stroke scale may be performed if feasible, but it should not delay imaging. Blood samples are drawn for essential investigations such as CBC, electrolytes, renal function, coagulation profile, and blood glucose if not already checked. However, do not delay imaging while waiting for reports. Time targets. Door to physician evaluation, ideally within 10 minutes. Stroke team activation within 15 minutes. Door to CT initiation within 20 minutes. CT interpretation, ideally within 45 minutes. After CT scan is completed and interpreted, ideally within 45 minutes of arrival. Now the treatment pathway becomes clear. If the CT shows intracranial hemorrhage, thrombolysis is ruled out. Management focuses on ICH. If the CT shows no hemorrhage, ischemic stroke is suspected, and we immediately assess eligibility for intravenous thrombolysis. We reconfirm the last known well time, ensure the patient is within the treatment window, check for major contraindications, and control blood pressure to guideline limits. For patients with severe deficits or suspected large vessel occlusion, vascular imaging such as CT angiography is planned to evaluate suitability for mechanical thrombectomy. Once the CT scan confirms that there is no intracranial hemorrhage, our next task is to decide who is eligible for intravenous thrombolysis. Patients who present within 4.5 hours of stroke onset are candidates for thrombolysis with alteplase, provided there are no major contraindications. For patients who arrive after 4.5 hours but within 9 hours, we do not decide based on time alone. In this group, advanced imaging is essential. We look for core perfusion mismatch on CT perfusion or MRI, meaning there is a relatively small infarct core and a larger area of hypoperfused but salvageable brain tissue. Typically, we assess whether the core volume is less than 70 milliliters. The mismatch ratio is more than 1.2, the mismatch volume is more than 10 milliliters, and Tmax is more than 6 seconds. If these criteria are present and mechanical thrombectomy is not indicated or not planned, thrombolysis can be given. Without perfusion imaging in this window, thrombolysis is generally not performed. In wake-up stroke or unknown onset stroke, thrombolysis may still be considered if imaging helps us identify salvageable brain tissue. If MRI shows a DWI flare mismatch and thrombectomy is not planned, alteplase can be given. Similarly, if CT or MRI perfusion demonstrates core perfusion mismatch within 9 hours from the midpoint of sleep, thrombolysis may also be performed. In minor non-disabling stroke, thrombolysis is generally avoided. However, if minor stroke is associated with large vessel occlusion, treatment may still be considered. If the patient is rapidly improving but still has a disabling neurological deficit, thrombolysis should not be delayed. We do not wait for complete recovery. In clinically severe stroke presenting within 4.5 hours, thrombolysis should be given. Even if there are early ischemic changes on CT, treatment may still be considered in carefully selected patients, often alongside thrombectomy planning. For patients with large vessel occlusion who are candidates for mechanical thrombectomy within 4.5 hours, Tenecteplase at 0.25 milligrams per kilogram may be used instead of alteplase when intravenous thrombolysis is being given prior to thrombectomy, according to institutional policy. If the patient was already on antiplatelet therapy, either single antiplatelet or dual antiplatelet therapy or warfarin, thrombolysis can still be given. For patients on vitamin K antagonists such as warfarin, thrombolysis can be given if the INR is 1.7 or less. Contraindications for IV thrombolysis. Do not thrombolyze if intracranial hemorrhage/SAH on CT. Active internal bleeding. BP 185/110 mm Hg despite treatment. Recent head-brain related conditions, significant head trauma within 3 months. Intracranial or spinal surgery within 3 months. Prior ischemic stroke within 3 months. Recent surgery/trauma, major surgery within 14 days. Major trauma within 14 days. Arterial puncture at non-compressible site within 7 days. Recent bleeding, gastrointestinal bleeding within 21 days. Any ongoing or recent severe bleeding disorder. Coagulation abnormalities, platelets 100,000. INR 1.7 on warfarin. Markedly abnormal coagulation profile. During thrombolysis, check neurological status using NIHSS and blood pressure. Every 15 minutes during the infusion. Watching for any sudden deterioration, new weakness, headache, vomiting, agitation, drop in consciousness or seizure activity. If severe headache, acute neurological worsening, nausea or vomiting, or a sudden rise in blood pressure occurs, stop the infusion immediately and urgently evaluate for intracranial hemorrhage. Blood pressure must be kept at or below 180/105 millimeters of mercury. Treat promptly if it rises above this level. Avoid intramuscular injections, arterial punctures, nasogastric tubes, Foley catheter insertion, and other invasive procedures unless absolutely essential. Once thrombolysis is completed, patient care must follow a structured ward monitoring protocol to ensure safety and better recovery. Immediately after thrombolysis, continue close neurological and blood pressure monitoring. Check neurostatus and BP every 15 minutes for 2 hours. Then every 30 minutes for 6 hours. And then hourly until 24 hours. Keeping blood pressure at or below 180/105 millimeters of mercury. Any sudden neurological worsening, severe headache, vomiting, seizure, or blood pressure surge should raise concern for intracranial hemorrhage and requires urgent evaluation. Do not give antiplatelets or anticoagulants in the first 24 hours. A repeat CT or MRI must be done at 24 hours or earlier if deterioration occurs, and only then should antiplatelet therapy be started. Maintain oxygen saturation above 94% and correct hypotension or hypovolemia to support brain perfusion. Temperature must be controlled. Identify and treat fever promptly and administer antipyretics if the temperature is 38 degrees C or higher, because fever worsens neurological outcomes. Glucose control is essential. Treat hypoglycemia immediately and avoid persistent hyperglycemia. Aim to maintain glucose roughly in the 140 to 180 milligrams per deciliter range with careful monitoring. Before giving any food, fluids, or oral medications, perform a dysphagia screening to prevent aspiration. If swallowing is unsafe, use nasogastric feeding early and consider PEG if long-term feeding difficulty is expected. Ensure appropriate nutrition and consider supplements in malnourished or high-risk patients. For immobile patients, prevent deep vein thrombosis using intermittent pneumatic compression, along with hydration and routine limb care. Mechanical thrombectomy is a powerful treatment for acute ischemic stroke caused by large vessel occlusion in the anterior circulation. Patient selection depends on both time window and imaging. In the 0 to 6 hour window from symptom onset, thrombectomy should be performed when all key criteria are met. The patient had good pre-stroke function with modified Rankin score 0 to 1. There is an occlusion in the internal carotid artery or proximal MCA M1 segment. The patient is 18 years or older. NIHSS is 6 or more. ASBECTS score is 6 or more. And treatment can start within 6 hours of onset. Either a stent retriever or aspiration technique may be used. Beyond 6 hours, treatment is imaging-based, not only time-based. We select patients only when imaging shows a small infarct core and a larger area of salvageable brain. Between 6 and 16 hours, the Diffuse 3 trial guides us. Eligible patients have a large vessel occlusion in ICA or proximal MCA. A core infarct less than 70 milliliters. A perfusion mismatch ratio 1.8 or more. A mismatch volume at least 15 milliliters. And evidence of hypoperfusion with Tmax greater than 6 seconds. These patients should undergo thrombectomy. Between 6 and 24 hours, the DAWN trial criteria apply, using a clinical core mismatch approach. Patients benefit when neurological deficit is severe but infarct core is small. For age 80 years or above, NIHSS 10 or more with infarct core under 21 milliliters. For patients under 80, either NIHSS 10 or more with core under 31 milliliters, or NIHSS 20 or more with core between 31 and 51 milliliters. These carefully selected patients can safely benefit up to 24 hours from last known well. Guidelines state, from 6 to 16 hours, thrombectomy is recommended in DAWN or Diffuse 3 eligible patients. From 16 to 24 hours, thrombectomy is reasonable in appropriately selected DAWN-based patients. These recommendations are specific to anterior circulation. Posterior circulation is handled separately. Technically, the goal is to achieve successful reperfusion to MTICI 2B or 3. And even in extended windows, treatment should be done as fast as possible, because earlier reperfusion still means better outcomes. Mechanical thrombectomy significantly improves survival and functional independence when the right patients are selected. Even beyond 6 hours, modern practice focuses on identifying salvageable brain with advanced imaging and saving it before it is lost.